Good day everyone. Today we are going to discuss the branch of the Bern station, and the main branch here is ARDS, or acute respiratory distress syndrome, or you can call it adult respiratory distress syndrome. They are going to give you a scenario, and this scenario is about a gentleman, old gentleman, post-operative on his day 4, day 5, and he has many comorbidities. Could be COPD, ischemic heart disease, and maybe diabetes type 2. And actually the nurse is telling you that his oxygen saturation on the room air dropped to less than 80. Okay, so the first question here, there will be 12 questions in this branch, so please focus. We are going to move fast here. What is your differential diagnosis? Number 1, it is pulmonary embolus. Number 2, it is chest infection. Number 3, it is pulmonary edema. Number 4, it is basal atelectasis. And number 5, it is acute coronary syndrome. Next question, question 2, how would you investigate initially? So your investigations here, you are going to give a full answer, and please focus on this because this will determine your marks. So first of all, this is a critical case. You are going to manage him according to the ABCDE approach, as usual, as we mentioned in the previous lectures. And following that, you are going to do routine blood investigations, ESR, CRP, BMP, procalcitonin, chest X-ray, then you are going to ask, and also ABGs. You may need to do ECG. All your investigations are dependent on your differential diagnosis. Remember that all the time. You set 5 differential diagnoses, you are going to investigate according to them. So after that, you are going to mention, I'm going to take medical or anesthetic opinion, okay, and this will depend on the investigations, the results of the investigations, okay. So if the clinical picture from your investigations show that this could be a pulmonary embolism, because it is one of the differentials, you have to ask for CTPA, CT pulmonary angio, okay. From this point here, they will go to the next question, the third question. So they told you that CTPA is done, it is negative, and there is marked consolidation on the X-ray on both lung bases. So how would you manage this patient? You are going to say that I would manage this patient according again to the ABCD. I cannot stress enough on this. ABCD approach for any critical patient will show the examiner that you are professional, okay? So you are going to manage him according to the ABCD manner, okay? First of all, you are going to check the airways, they are patent. You are going to start oxygen, and you may need, if necessary, because there may be pulmonary edema here, you may give intravenous fluids. You do not want to worsen the situation, okay? Then after that, you may commence on antibiotics, and on this actually you are going to depend on the local policy or the guidelines, and you are going to start chest physiotherapy, okay. This is what are you going to do to manage this patient in this stage. Let us go to the fourth part, and they told you that your management is not working, the patient is not responding. So you repeated the chest X-ray following your treatment after 3 days, and you found an X-ray which has diffuse bilateral pulmonary infiltrates. There are 2 options. They may bring you an X-ray that contains diffuse bilateral pulmonary infiltrates, or they may tell you just like that. So what is your diagnosis? So you want to know that the main criterion, the main feature for ARDS or acute respiratory distress syndrome is diffuse bilateral pulmonary infiltrates. This is diagnostic, okay? So let us go to the next question. What is acute respiratory distress syndrome? You want to define now. And the definition will be like this. Just memorize it just like that. Acute respiratory distress syndrome, my dear, is a clinical syndrome. Okay? And it is comprised of acute respiratory failure, number 1. Number 2, you will have non-cardiogenic pulmonary edema. These are the 2 features of ARDS. Acute respiratory failure, patient cannot keep his oxygenation, and there is pulmonary edema, but you want to mention that it is non-cardiogenic pulmonary edema. Those 2 form the ARDS. So actually what will happen here? hypoxemia, he cannot breathe actually, respiratory system is failing, okay? So you have low oxygen, and actually the worst point here is that the patient is refractory to oxygen therapy. He is not responding to oxygen therapy, okay? The sixth question will be, they are going to ask you, what is the difference between ALI and ARDS? ALI is acute lung injury, okay, and ARDS is acute respiratory distress syndrome. Actually, they represent a spectrum of the whole disease, okay. So ALI is initial and ARDS is the result. It is the most severe form of the disease, okay. Are you with me? So you want to know how to identify the etiology of each, okay? They are characterized by, as we mentioned, they have non-cardiogenic pulmonary edema, okay? There are diffuse pulmonary infiltrates on chest X-ray, there is progressive hypoxemia, and there is reduced lung compliance. This actually you cannot measure, but this is a pathological part of the situation. So let us move to the next question. I think that is the sixth question now. And here, they are going to ask you, how would you diagnose ALI and ARDS? How can you diagnose them? Both of them are the same way for diagnosis. So you have 5 points here. Point 1, they are both acute on onset. This is one of the features, this clinical diagnosis. Number 2, you have diffuse pulmonary infiltrates, bilateral diffuse pulmonary infiltrates, again on X-ray, okay? Number 3, the pulmonary artery wedge pressure, if you are measuring it in the ICU or ITU, it is less than 18 millimeter mercury. Number 4, PaO2 over FiO2 is less than 40 kPa in acute lung injury, and it is less than 26.6 kPa in acute respiratory distress syndrome. This can be explained on a later day after you have finished your examination, but now you want to know it, okay? You want to know it just like that. You want to reply the question, but there is an explanation, scientific explanation for that, medical explanation, okay? So, okay, let us go to the next question. What are the potential causes of ARDS? What may cause acute respiratory distress syndrome? Okay, so you are going to divide them into 2 categories. The first category, it's primary lung cause, and the second category is others. Okay, well, so let us start with the primary lung causes. This is a burn station. So the first cause is smoke inhalation, right? Okay, it could be trauma, multiple trauma, it could be pneumonia, it could be fat embolism. All these are causes. These are things directly related to the lung, aspiration to the lung, trauma to the chest or the lung, fat embolism that travel to the lung or to the pulmonary veins, and smoke inhalation, smoke by the lung. These are primary, okay? Let us go to the others. Multiple trauma, okay, polytrauma, generalized sepsis, septic shock. This is one of its complications actually, and actually if sepsis is there, the mortality will be so high, as we see later. Massive transfusion, all of you know that. DIC, disseminated intravascular coagulation, we already discussed that before in a previous lecture. And cardiopulmonary bypass operation, this may happen also. Let's go to the next question. I think this is the 7th one. I don't know, right? So what is your management for ARDS? So to be honest here, don't tell this to the examiner, there is no treatment for this disease. Actually, the body heals itself. But you are going to do some general supportive measures and some other specific management aids. So you may help, okay? Because this actually, you need, you want to finish this, do these things and pray only, okay? Because the mortality is high here. So you are going to do supportive treatment, and you want to treat the underlying cause if there is any. If sepsis, you want to treat it. If trauma, you want to manage. If it is shock, you want to treat it. Whatsoever the IC, whatsoever you want to do it to support the patient. And specifically, you are going to do some measures. Number one, you are going to use mechanical ventilation, okay? And in this case here, we are going to use PEEP, end expiratory, positive end expiratory pressure, and by this way you are going to keep and splint the alveoli, and they are going to be open all the cycle, okay? Number two, you are going to reverse the respiratory, the expiratory ratio, I to E ratio. So usually we are taking in half of the time and double the time we breathe out. You are going to reverse that. So inspiration will be double the time of expiration. So this will give some way to raise the oxygenation. Number three, you are going to ventilate the patient on prompt position. So you are going to improve the VQ mismatch, improve the VQ mismatch, okay? So number four, you may use something called ECMO, and ECMO is still under trials. I think that it is approved in some countries, but you can mention it in the exam, and you have to mention, if you mentioned ECMO, you want to mention that there is a complication of bleeding that may happen, okay? You may use some drugs also. We will mention this in another question. You want to take care of the nutrition, and you want to be careful that the central venous pressure is low most of the time, because you want to reduce the pulmonary microvascular pressure. So let's go to the next question here, and the next question will be acute about ARDS, pathogenesis, about the pathogenesis of acute respiratory distress syndrome. These are very simple steps, okay, and there are about 5 or 6 steps that will help you to know about the situation. So number one, there is an insult, a problem that will happen. It may be direct or indirect to the lung or from any other cause. The next step here will be activation of the inflammatory cells and mediators, okay? Number is usual, okay? Number three, there will be, due to that, there will be damage to the alveolar capillary membrane. Number four, there will be an increased permeability of the alveolar capillary membrane. Number five, there will be an influx of protein-rich edema fluid and inflammatory cells into air spaces, and the surfactant will be dysfunctional, so there will be a collapse on the alveoli. This is the ARDS. That is why when you give oxygen, there is no place to get taken by the body, because the alveoli, the respiratory units of the lung, are not working, okay? Let us move to the next question, and actually this is the last question. They are going to ask you about what are the pathological changes that occur in acute lung injury and in acute respiratory distress syndrome. We mentioned that those are the different spectrums of the same disease. So what is, and you want to mention also what are your treatment principles. So actually there is some sort of classification here. And there are many phases, okay? Those phase one, it is inflammation and exudation, as we mentioned in the pathogenesis. Phase two, it is the proliferation. Phase three is the fibrosis, and phase four is the healing, okay? If any, if it happened, okay? So the inflammatory or inflammation or exudation phase usually takes about 1 to 2 days. This is acute inflammation, okay, response to trauma, inhalation, whatsoever. So the pathology, this is mediated by macrophages and neutrophils, as you know, and here cytokines are released, proteases, and there are many free radicals released, and the interstitial alveolar edema occurs because of this inflammation, and the hyaline membranes may be formed. So what is the treatment in this situation? Supportive, as we mentioned before here, ABCs, and you are going to do some support for the patient. Then if that failed, you are going to move to the next stage. You want to treat the cause, number two. Number three, you want to use ventilation, PEEP ventilation, positive end expiratory pressure. You want to keep the alveoli open all the time. Number 4, you want to inverse the ventilation. As we mentioned, inspiration should be double the time of expiration, okay? And you are going to ventilate the patient in, as we mentioned, ventilate him in prone to improve the VQ match. The second phase is proliferation, and actually this takes about 1 to 2 weeks, okay? What happens here? There is proliferation of type 2 pneumocytes, and there is proliferation of fibroblasts. So here there is granulation tissue, because now we are in the healing process, but it has bad consequences. So this will lead to the narrowing of the alveoli and the vessels around, okay? What is your treatment principle here? You are going to give nitric oxide. In this case, we told about some medications that we are going to use in the management of ARDS. This is one of them. Nothing approved, but it is helpful, okay? So you are going to use it, and it has been found that it improves VQ match and it improves ventilation in the areas of the lung. Okay, so this proliferation, the second phase. The third phase is fibrosis, and usually it takes about 2 to 4 weeks. And here there is significant pulmonary fibrosis that may occur in some patients. And some patients, they may be lucky. But in all situations, you are going to use these steroids in this case, if they are useful. Nobody knows. What is the mortality rate for ARDS? In general, it is 50 to 60%. And what is the mortality rate of ARDS? If the patient has sepsis, it is almost 90%, so there is no chance for the patient, or very, very small chance. Mrcs is always there, okay? This is the station, burn station, now finished with ARDS as a branch, and I'm going to see you in the next station later. Good luck.